Hello students, I am Dr. Hanumanth, Associate Professor from the Department of Orthodontics and Dentofacial Orthopedics, Vinayaka Mission, Shankaracharya Dental College and Hospital. And today's topic we are going to take on Anchorage. So coming to the topic, these are the contents. So you have the first thing is the definition, classification, we have the sources of anchorage, anchorage reinforcement, we are going to talk about anchor loss and the references. To start with the definition, so according to Graeber, he defined anchorage as a nature and degree of resistance to displacement offered by anatomic unit for the purpose of effecting tooth movement. According to Profit, he said that anchorage is resistance to unwanted tooth movement. Moyers defined anchorage as resistance to displacement. Basically what anchorage means is it's a resistance to displacement for effecting a perfect tooth movement. So coming to the classification, we have the classification under various headings. The first one is according to the manner of force application. So based on the manner of force application, we have something called a simple anchorage, we have a stationary anchorage, we have something called as reciprocal anchorage. According to the jaws involved, we have intramaxillary and intermaxillary. Coming to the third part, that is according to the site of anchorage, we have three sources. We have an intraoral source, we have an extraoral source, and we have a muscular source. Under extraoral source, the anchorage could be taken from the cervical aspect, occipital aspect, cranial aspect, and the facial aspect. According to the number of anchorage units, we have single or primary anchorage, we have compound anchorage, we have multiple or reinforced anchorage. So coming to the first one is the simple anchorage. What is a simple anchorage? As you can see in the picture here, you can see that a premolar, second premolar needs to be moved outside. Basically, we need something called a tipping type of tooth movement to push this premolar buccally. So this resistance to tipping, that is, the tooth is free to tip during tooth movement. Here, the application of the force tends to change the axial inclination of the tooth or the teeth that form the anchor unit. Thus, the resistance of the anchorage unit to tipping is utilized to move another teeth or tooth. In this picture, you can see there is an expansion screw that is placed in order to affect the buccal movement of a second premolar. The anchorage source is taken from the rest of the teeth from the same arch, and this premolar is free to tip. Coming to stationary anchorage. What is a stationary anchorage? A stationary anchorage is nothing but a resistance to a bodily movement. That is, the tooth is only permitted to translate. So we have different types of tooth movement, as you all know. We have tipping, we have rotation, we have intrusion, we have extrusion, and there is a tooth movement called as translation, where the entire crown and the root of the teeth needs to be moved. So when a resistance is required in order to effective a bodily movement of the teeth, that is called as stationary anchorage. The dental anchorage, in which the manner and application of the force tends to displace the anchorage unit bodily, is called as a stationary anchorage. Next, coming to reciprocal anchorage. What is a reciprocal anchorage? When you need two or more teeth moving in opposite directions and are pitted against each other by the appliance, usually the resistance to each other is equal and opposite. For example, in the first picture, you can see there is a midline diastema that is present between the two central incisors. We need to close this midline diastema by pushing both the teeth equally towards the midline. So each tooth, that is, for example, you have 1-1 here and you have 2-1 here. 1-1 serves as an anchorage for 2-1 and 2-1 serves as an anchorage for 1-1. So both the teeth equally and effectively gets moved towards the midline and the midline diastema gets closed. That is the first example. In the second example, you can see there is a crossbite that is present in the posteriors, especially in the molar. It's a single tooth crossbite. So in such cases, we use something called a cross elastics. These cross elastics are effective in order to correct the cross bites, whereby the maxillary molars are pushed buccally and the mandibular molars are pushed lingually. So both the teeth move effectively in order to correct the cross bite. So this is another example of a reciprocal anchorage. The third example is the use of an removable appliance which incorporates a screw for expanding the maxillary arch. So you can see this jack screw which is present in this midline is used effectively to create an expansion of the maxillary arch, thereby pushing both the right side and the left side of the arch equally outside. So this is another example of a reciprocal anchorage. Anchorage is mainly obtained outside the oral cavity. So coming to what is intramaxillary anchorage. The word intra means within the same. So anchorage in which the resistant units are all situated within the same jaw. As you see in this picture, you can see that in order to effect the expansion of the right side of the arch, we take support from the left side of the arch, where the anchorage units are situated within the same jaw. So here is a classical example of an expansion device employing the teeth of the same jaws as anchorage units. This is called as intramaxillary anchorage. Coming to intermaxillary anchorage. What is intermaxillary anchorage? Intermaxillary anchorage is nothing but you take an anchorage from the opposing arch. For example, you can classically look this picture where you see that these elastics, which are called as class 2 or class 3 elastics, are employed in such a way that in order to effect the movement of the maxillary anteriors, we take support from the mandibular posteriors. So anchorage in which the resistance units situated in one jaw are used to effect the tooth movement in the other jaw is called as intermaxillary anchorage. It is also termed as Baker's anchorage. For example, class 2 and class 3 elastic traction to treat interarch discrepancies come under this category. So now coming to what is intraoral anchorage. So any anchorage sources which are taken from intraoral sources, like for example teeth, root, basal bone, are all categorized under intraoral anchorage. So anchorage in which all the resistant units are situated within the oral cavity, as I had mentioned before. The teeth to be moved and the anatomic areas that offer anchorage are all within the oral cavity. Various intraoral anatomic units that may be employed are the teeth, palate, lingual alveolar bone of mandible. Coming to extraoral anchorage. Extraoral anchorage are nothing but they use extraoral sources in order to produce an effective tooth movement. It could be from the cervical region where they utilize the neck for anchorage. For example, neck straps are used. It could be occipital where they utilize the occipital region for anchorage. For example, headgears. Cranial involving the cranium as a source of anchorage. For example, high pull headgears are used. And facial, it involves the facial aspect of the face where it is used as a source of anchorage. Especially the forehead and the chin are utilized in case of face mask. A face mask is nothing but it's a device where it is used to correct a skeletal class 3 in a growing patient. So in such cases, the support is taken from the, you can see, from the forehead as well as from the chin. Intraorally you have an appliance placed. The elastics are placed from the external device to the intraoral sources of the teeth. Thereby it causes a maxillary traction outward in order to correct a skeletal developing class 3. So the source of anchorage here is the forehead as well as the chin. Like for example, even headgears, as I had mentioned before, the headgears are taken support from the occipital region, okay, or it can be taken even from the parietal region, where in order to effect a tooth movement, or if you want to control the growth of the upper jaws, where you don't want any kind of unwanted movement of the upper jaws as well as the teeth. In such cases, the anchorage sources are taken from the skeletal, that is either parietal or the occipital region, where headgears are given to produce effective tooth movement or to also to control unwanted tooth movements. Now coming to muscular anchorage. What is a muscular anchorage? Anchorage in which the perioral musculature is employed is as resistance units is called as a muscular anchorage. In this case, we can give an example of a lip bumper where the anchorage is derived from the perioral musculature in order to produce either a distal movement of the lower molars, or you want to correct any kind of unwanted abnormal muscular force which is impairing the tooth movement, especially in the lower anteriors. In such cases, you can use effectively these muscular anchorages either to correct the tooth movement, also to prevent unwanted tooth movement. So next, coming to single or primary anchorage. What is a single or a primary anchorage? A resistance that is provided by a single tooth with greater alveolar support is used to move another tooth with lesser alveolar support. That is called a single or a primary anchorage. So a single tooth, in this case, a single tooth is used as an anchor source to effect a tooth movement of another teeth. For example, a lower molar or an upper molar which is having a better root surface area can be used as a anchorage sources to effect a tooth movement of the other tooth. Coming to compound anchorage. What is compound anchorage? Anchorage where the resistance provided by more than one teeth with greater support is used to move teeth with lesser support. So here one or more teeth are used as an anchor source in order to effect a tooth movement. So that the tooth movement is affected in a tooth with a lesser support. So tooth with greater support, in such greater support in the sense like for example instead of involving 1 or 2 teeth, even you can involve 3 teeth to affect a tooth movement. Such cases are called as compound anchorage. So now next coming to the sources of anchorage. So orthodontic tooth movement is produced by forces that are derived from active components of orthodontic appliances. These employ anchorage that can be either intraoral or extraoral. Coming to the intraoral sources, the intraoral sources could be alveolar bone, teeth, basal bone or a musculature. So coming to alveolar bone, when a force is applied to move a teeth, rearrangement of alveolar trabeculae occurs to offer resistance to the force. In an ideal anchorage situation, the reactive force is distributed over enough root surfaces to cause only this rearrangement, beyond which the bone yields, permitting tooth movement. So as we all know, the teeth is supported by a bone. So in order to affect a tooth movement, you need a good alveolar bone support in order to affect a tooth movement. That is what is described here. So in such cases, you need a very good alveolar bone support for effective tooth movement. Coming to the teeth. The teeth themselves can resist movement. As I had mentioned before, in a simple and compound anchorage, where we spoke that in a simple anchorage, we need one tooth as a source for anchorage. In a compound anchorage, we need multiple teeth. So here, the teeth themselves can resist movement, although this ability varies greatly. What are the variations? It could be based on the size of the teeth, based on the number of the teeth, it could be based on the length of the teeth, position, and also the inclination of the roots, which play a major factor in affecting a tooth movement. So coming to the root form, the root cross sections basically can be of 3 types. It could be round, it could be flat, it could be triangular. So round roots are generally seen in bicuspids and the palatal root of maxillary molars, and it contains only 50% of their periodontal ligament fibers to resist a horizontally directed force, and its resistance is the same in any direction. Coming to flat roots, for example, we can take the example of mandibular incisors and molars and the buccal roots of maxillary molars, where they can resist movements in the mesiodistal direction but have little resistance to movements on their edges found on the buccal as well as on the lingual sides. Triangular roots of the canine and the maxillary central and lateral incisors permit tensing of almost 2/3 of their periodontal ligament fibers when pushed, and the moderate flat surface on one side adds to the resistance. Coming to the size and the number of roots, always it's known the fact that a multi-rooted teeth with larger roots have a greater ability to withstand stress, since the greater surface area has more number of PDL fibers and hence increases its stability. And one more to add to it is, when you have a root with a dilaceration, I hope you understand what a dilaceration is more of a curved root. In such cases, the resistance offered by such teeth is more. So that can be employed as an anchor unit. So the size and the number of root plays a very important role in anchorage. For example, you have mandibular molars and the maxillary molars. You have 3 roots in the maxillary molars, you have 2 roots in the mandibular molars. That is the reason why these molars are taken as a source of anchorage when we do fixed orthodontic therapy. And also teeth with larger roots. For example, you have the canines, which has a longer root. Such cases, if you want to effect a good posterior protraction of teeth, posterior protraction meaning where you want to mesialize the molars or the premolars, in such cases we take the support of the canine which has a longer root in order to employ the tooth movement in such cases. Coming to the root length. The root length indicates the depth to which it is embedded in the bone, as I had mentioned before, and the deeper it is embedded, the stronger it is the resistance to dislodgement. So the root length also determines is an important factor and determines the effective tooth movement. So so basically when you employ teeth which are as anchors, you should make sure that you employ teeth in such a way that they are either multi-rooted teeth, they have larger surface area, as well as they have longer roots. So these are the tooth which is used as an anchor sources for effective tooth movement. Coming to the position of the tooth in the arch. So this also plays a very significant role when they act anchors. Position of the teeth in the arch may be significant, as in the case of mandibular second molar, which is located between 2 high ridges of basal bone mesial to the retromolar fossa, that is the mylohyoid line and the external oblique ridge. Due to its position, it offers more resistance to bodily mesial movement than any other tooth in the mouth. Coming next to the inclination of the roots. So the axial inclination is another important factor in assessing the value of a tooth as a source of anchorage. A greater resistance to dislodgement is offered when the force is opposite to the axial inclination. As the force is partly extended down the axis of the root to the underlying bone, more of the tooth's pedial fibers are tensed, causing the root to dig in. So coming to mutual support. In addition to the above mentioned factors contributing to the anchorage potential of teeth, the mutual support offered by the relationship to other teeth in the arches should be considered. Teeth mutually supporting each other can best contribute to the overall resistance value when they are aligned, because the reactive force can pass in a relatively straight line through the contact points and receive maximal support from each tooth. Ankylosed teeth. Another factor is the ankylosed tooth which are directly fused to the alveolar bone. Hence, the absence of periodontal ligament does not permit them to be moved orthodontically. Thus, these ankylosed teeth can be used as a source of anchorage whenever possible. These ankylosed teeth generally are fused to the bone. They don't have any pedial fibers. So, in such cases, it is very difficult to move these teeth if we want to move it orthodontically. So, in other words, if you want to effect a good orthodontic tooth movement, these ankylosed teeth, if they are present in the arch, can be used as a source of anchor for effecting the other tooth movement. Coming to the basal bone. Certain areas of the hard basal bone available intraorally are as sources of anchorage, providing stability of the immobile type. These areas, such as the hard palate and the lingual surface of the mandible in the region of the roots, augment intramaxillary or intermaxillary anchorage. Coming to the musculature, the normal tonus of the facial and masticatory muscles exert pressure on the dentition to equalize the pressures from within, has an important part in molding the form of the dental arches. In addition, abnormal musculature tone also has its effects. Hypotonic muscles, for example, permit flaring and spacing of teeth, while hypertonic muscles exert forces in a lingual direction. The stability of the anchorage of a dental arch may be increased by temporary utilization of hypertonic labial musculature. Coming to the extraoral sources. In most instances, extraoral anchorage is used in cases where the resistance offered by the intraoral sources is insufficient. So, when you use your intraoral sources like your teeth, root and basal bone, when you find those sources are found to be little insufficient, you need better support. In such cases, extraoral sources are used. So, the extraoral anchorage can be used to stabilize the position of the teeth. For example, distally directed extraoral force applied to upper first molars to prevent their mesial movement. Produce mesiodistal, vertical and angular changes in tooth positions, and also to produce an orthopedic change. So, the various extraoral sources include various areas of head and face, which we have discussed already before, such as cervical region, occipital region, parietal region, frontal region, as well as the chin region. So, these appliances that employ the extraoral anchorage are headgears or face masks. Headgears derive anchorage either from the cervical, occipital, parietal regions or a combination of these. Face masks derive anchorage from the chin or forehead, or both. The variables associated with the use of extraoral appliances necessitates the understanding of their mechanical action. Basically, you need to know how they work. The mechanics involved are related to their duration, that is basically the duration of the wear, the magnitude and direction of force, in which direction the force is applied. For example, if we want a distal movement, we need more of a distal force of the headgear, whereas in a reverse pull headgear or a face mask, we need more of a mesial movement of the maxilla to get corrected. So, the magnitude and the direction of the force plays a very important role, and careful consideration must be given to them to achieve the desired results. So, now coming to anchorage reinforcements. Whatever said and done, we might have some kind of issues with anchorage when we employ the teeth as an anchor. So, in such cases, in order to effect a very good tooth movement, you can also employ some extraoral devices or intraoral devices or something which gives a more of a reinforcement. Those things are called as anchorage reinforcement. The process of increasing the anchorage value of the reactive segment to resist anchorage loss is called anchorage reinforcement. So, the reaction force is distributed over a large PDL area, which reduces the pressure on the anchor units. This can be done in a number of ways, by incorporating more teeth, or you can add something called appliances, intraoral appliances, which can be added to effect such things, or to create more of reinforcement, such as the transpalatal arch, lingual arch, Nance holding arch, or an extraoral or intermaxillary traction. So, when we don't employ such reinforcements, or when we have an anchorage source which is very weak, in such cases we might develop something called an anchor loss. What is an anchor loss? Nothing but an undesirable movement of the reactive anchorage segment which happens as a side effect of the movement of the active segment. So when we want a maximum anchorage, for example, in this picture, you can see that the first premolar has been extracted. We want maximum of anterior retraction to take place into this extraction space. So in such cases, we need 75% of the maxillary anteriors to move into this extraction space, which is called as maximum anchorage. When you have a moderate anchorage, it's basically a 50-50 situation where you need 50% of retraction of the maxillary anteriors and 50% of protraction of the maxillary posteriors. So the anchor teeth is permitted to move forward into 1/4 to 1/2 of the extraction space. That is called as moderate anchorage. Coming to minimum anchorage, in this case the anchorage demand is low. So more than half of this extraction space is utilized by the posteriors or the anchor teeth by moving them mesially. This is called as minimum anchorage. It can be also grouped as Group A, Group B and Group C anchorage. So these are the references for the topic anchorage. So you can go and refer. These are the books like Contemporary Orthodontics by Profit, Textbook of Orthodontics by Gauri Shankar, or Textbook of Orthodontics by Balaji. So you can go and refer this topic in these books, which will give you a much better idea about the same. Thank you for your patient listening. Thank you.